Hello and welcome to the Pain Options Education channel. I'm Darren.
I'm Tim.
And we're continuing our series, the Pelvis series, and today we are talking about deconstructing the subjective interview. So I'm looking forward to hearing your thoughts on this, Tim. This is just a reminder of where we sit in terms of our journey through the pelvis here. So we've talked about the problem of the pelvis, we've spoken about breaking down the assessment paradigms, and today we're up to the subjective. Again, our main goal here is to just try and stimulate thought processes and enhance clinical reasoning around this topic. So I've built this slide, Tim, just around differential diagnosis. I think, last time we spoke about pelvic girdle pain, problems with the sacroiliac joint not being as common as potentially other disorders around the lumbar spine and probably even the hips as well. So differential diagnosis in terms of a structural or a source of symptoms is really important in this discussion. Probably I would almost start at a point of differential diagnosis, and as we heard with the... I need to start again. This is just shit. Sorry.
Go back to the slides. Now go forwards again.
Okay. I built this slide, Tim, around differential diagnosis. I think this is just really important in the pelvis, particularly with the prevalence of disorders within the pelvis probably not being as high as the lumbar spine, probably even not as common as the hip. And just really then, if you're looking at a source of symptoms, really thinking from the outset, I need to differentially diagnose from those other structures to come to the conclusion that the pelvis is a primary issue in the condition.
Yeah, I think there's two parts to that. One is when people come to see you, they want to know what's wrong and where's it coming from. So that's the important part of that. So to be able to be skilled enough to assess that. But the second part is to be skilled enough or have enough understanding to decide when you really need to chase an individual structure. And certainly there's times when I think that's extremely important and other times when it's maybe less relevant, but we'll come to that, I think.
Okay, good. So really we've just got these list of items you might speak to during the subjective examination. I just thought we'd go through them kind of one by one and see what we think. So number one here is screening. So this is really around using screening questionnaires, particularly to just look at risk overall, would be one way to do that. So in the low back, we have the start back questionnaire. More broadly, we have the Orabro. And, there isn't a specific risk assessment tool like those for the pelvis, but certainly either of those would probably be adequate.
Yeah. I mean, we use the Orabro in our clinic because it covers all musculoskeletal conditions. But that's really a screen for psychosocial risk.
Yes.
Which is very important, but that's not the only part of screening there, is it?
No. So what other screening things you got?
Well, the obvious one is the red flag disorders.
Yeah.
So, and certainly that's possible with people presenting with symptoms around the lumbar pelvic region. So using both a general health screening questionnaire, but also then individual questions that you might ask for additional detail depending on the person's story of what they're presenting with around their symptoms.
Yeah, and that's important around comorbidities for this problem as well. I was thinking something else about screening, and now I've forgotten. It kind of leads into etiology a little bit around specific diagnosis versus a non-specific diagnosis, and I just kind of flicked into my mind around stress fractures. So you can have stress fractures through the sacrum or the pelvis, so a history of other conditions like that, but again, maybe I'm drifting more to comorbidities there.
Yeah. Well, if we think about that, the etiology side of it, what do you mean by that? It's a fancy term.
It is.
Yeah.
It's really just the cause of symptoms. So in the literature, it tends to speak of, an inciting event where there's some kind of load or force through the pelvis, typically cited as falling on your bum.
Yep.
Or in a car accident where maybe there's force transmitted through the leg.
Missing a step, that's another one.
Yeah.
A bit.
Yeah.
Or picking something up or bending over there, what people will describe that people then think might relate to sacroiliac joint pain.
Yeah, that's right. Yeah. And certainly there is these insidious kind of onset ones as well.
So on that, we now we don't use etiology because we can't say it or spell it, but we tend to talk about the story, don't we?
Yes.
So getting the person's story of what's wrong. So before you dive into where the symptoms are coming from, tell me about your problem. What's the background to this problem starting? And as we said earlier, in the absence of major trauma, which you see occasionally, and obviously there's obvious indications then that this person needs investigations done because there's been obvious trauma. There's not that many things that would concern us around the story unless you're going more to that insidious onset group where maybe there's more general health factors, as I think you were mentioning, or other comorbidities where someone has underlying conditions or a spondyloarthropathy or something like that, or their story of massive overload. I've seen sacral stress fractures in someone trying to break the world stair climbing record, for example, but that's over a 24-hour period on concrete steps.
Yeah.
So again, there's something there that fits the story of, hang on, maybe there's focal pathology here.
Yeah. And the other thing that just might be worth mentioning there is around pregnancy. Of course, these conditions can be more common during pregnancy, so that might be important in terms of what's precipitated the condition.
Yeah, on that though, because I had a discussion with a women's health physio group earlier this year. So you hear that, I'm pregnant, or you see some patients come in and they're obviously pregnant and they've got pain around this region. Again, the reasons why they might have pain aren't necessarily because their pelvis is loose or unstable, but pregnancy because of other reasons may be associated with increased pain in this region.
Yeah. And look, when I worked in a large women's health practice, I still saw many with back pain as kind of pelvic pain. So you still need to be careful around, again, that differential diagnosis.
Yeah.
Okay, so area of pain?
Yep, so what about their story around area of pain are the key ones for you?
Yeah, the key one is their main pain should be around the sacroiliac joint. The injection studies lead us to that. It's the vast majority of those many studies suggest that the pain does not refer upwards from there. It would only refer down. But I think they need to say, when they point to their primary pain, it will be over the posterior superior iliac spine / sacroiliac joint region. If they're pointing to their lower back, it's less likely to be sacroiliac joint. In terms of referral, there's lots. Well, if you take the pain maps from all the injection studies, basically it colours in the whole leg. But for me, most of them are pretty localised. There might be secondary muscular pain. That's something to look out for through the gluteals, the adductors, different muscle groups. And a referral down the symptoms certainly won't be a neurological pattern, and there's not as big a issue as what I see.
Yeah, so certainly clinically I see some that have pain referral down the leg and possibly to the groin or symphysis region occasionally. So they're probably the main ones. But like you said, around the lumbar spine comment, for me that's very helpful. So if you think of where the sacroiliac joints sit, then you've got that concept of, hang on, this person's pointing above that. Index of suspicion for sacroiliac joint pain suddenly becomes low quickly. So getting clarity around, show me where your pain is, and getting them to point, I think, is really helpful in that questioning phase, because then you can target your questions around the other symptoms from there.
And then clearly L5S1 and probably L4-5, if you look at the referral patterns from them, clearly refer into the region of the sacroiliac joint. So if they're pointing in their back, that kind of rules out the sacroiliac joint. But if they're pointing at the sacroiliac joint, you have to go to the lumbar spine.
Yes. But of course, some people say, but maybe some people have got both. But how often does that happen?
Not that much, I don't think. Not as one. You can usually find that one's a primary issue.
I agree with
Very important to ask around, is that your pain, or at least is that an area of your pain when you're assessing that?
Sure.
Area of pain, anything else?
No, I think they're the main. If we keep it simple around that, they're the key, the big ticket items.
Behaviours, what do you mean by behaviours, Tim?
Well, the behaviour of someone's symptoms, so they're the things we talk about in terms of aggravating factors or easing factors, whether they have morning pain or it gets worse mechanically over the day. So what would you see as a typical story? So someone's pointed to the sacroiliac joint area, so they've told you location of symptoms is there. What are you wanting to hear from their story that makes you think that their symptoms are related to that?
I think really you need to look out for things that relate to transferring load through the pelvis. So weight-bearing kind of activities, you know, where there is force through the sacroiliac joints, that would be the most common. And not because the pelvis isn't so much related to movement, that's the lumbar spine and hips, then it's not going to be such a story around movement. Now, if you've fallen over and hurt on your bum yesterday, you know, you might not be able to bend. But as you get over the acute pain, it would be more around taking load, probably, than movement.
So list those things off. What are classic features that people say
Sit
about
to
load?
well, sit to stand.
Yeah.
Standing, walking, putting their pants on, so having to lift one leg up, running, jumping, hopping, more, kind of impact things, I would call that. The kind of one flag in this is rolling, you know.
Yeah, you do see that, and I've seen that with people with sacroiliitis, for example, where rolling in bed is really painful.
Yeah, and pregnancy as well. So I just tell myself that there's a transitional load going through the pelvis during that movement, and that satisfies me.
Yeah, good, but that's different from the story of someone saying it's with specific movements that don't or are less associated with load. And I think obviously if something's extremely sore, then everything hurts, but it's really the loading activities, transfer load through the leg particularly, that are the strong features. Okay. And then easing of that, it obviously depends, as it always does.
Yes.
I mean, if someone's got an inflammatory underlying disorder in their sacroiliac joint, then they'll describe an inflammatory behaviour to their symptoms, so it might be constant pain. If it's more mechanical and the joint is sensitive, then usually there are easing or relieving positions and activities. But usually that's with reduced load bearing or more rest. I think are the key ones there. Any others?
No, I think that covers it.
Okay.
So the emotional side of pelvic girdle pain, certainly from
just to go back.
Go on there.
I just had another thought, as we often do. So around that we've talked about fairly mechanical symptoms, and then I mentioned something more inflammatory. So when the joint or the structures in that region are more sensitised, inflammatory would be one reason. So there's less mechanical pattern, so not clear aggravating or easing factors. But you can have other presentations where that whole region is broadly sensitised, such as pain sensitisation, without an inflammatory driver, where you'll have the same thing where everything hurts and there's not that clear mechanical behaviour as well. So I think we just need to be aware that you'll see that at times. Also.
Yes, and I expect you'll see a series from us on pain sensitivity at some point.
At some point,
yes. Look out for that one.
Topic.
Emotions. So certainly, you know, it's like any other pain disorder where emotions are related to the problem for many people. The research certainly supports that. You know, issues like depressed mood, fear, catastrophizing all come up at different times in the research as being important. Are those things that you see in these people?
Yeah, but it's easy to say if they're there in lots of pain disorders. Why, as physios, do we even need to go there, or do we need to know about that?
Yeah, well, what do you think?
Well, because they can potentially either be an initial driver or amplifier of symptoms. We mentioned earlier the screening with the short form Orabro. If you're not comfortable, that's a very easy way of just going through that questionnaire and say, I noticed you scored quite highly on your mood questions here. Do you think that's related to your pain, or can be a quick way in? But being aware those factors are there, tell us there's a possibility of that contributing to at least amplifying their symptoms.
Yeah, and my other favourite there is to, if you don't use the questionnaire, you don't have it, just to tag it onto the aggravating activities. So you've told me that, you know, walking, standing on one leg aggravates you. Some people also, you know, get aggravated by other things like their mood. Any problem for you? So that can be a nice way to address that if you're a bit reluctant to. Some people are.
Yeah, you're not always comfortable, but if you discuss it in context with their symptoms, obviously it becomes individualised, but I think most people are comfortable with that.
Yeah.
Yeah.
Well, the odd person would have come in and told you their worries before they said anything else.
Yeah, and the key is there to listen to that.
Absolutely. Beliefs. So we've been through, and I advise you to go back and look at our episode on treatment paradigms to really think about the beliefs. So many people with sacroiliac joint pain, pelvic girdle pain, do have beliefs related to the pelvis being out, their pelvis being sloppy, their pelvis being, loose, and this certainly leads to a lot of different behaviours around avoidance, passive coping being the big two, and this is a problem we see a lot of.
Well, it is. Unfortunately, it's a health practitioner and community knowledge driven problem. So if you see these people early on and they haven't seen anyone else, it's usually less of an issue. But if they've had other health practitioner input or a family member or friend that's given that concept, then, you think if you think your shoulder's unstable, you're not going to be throwing a ball. If you think your sacroiliac joint's unstable, you're not going to be doing lots of things because that takes load for so many activities.
Another belief that's really important in pelvic girdle pain, but all disorders, is the expectations of recovery. Yeah. But a number of studies have shown that's a big predictor in pelvic girdle pain during pregnancy.
So in your questioning, why do you need to know about beliefs? So if you find some information out from your patient about their beliefs, what do you need to do about that, or how does that help you?
Yeah, I'm sure we'll talk about that in management, but first of all, you need to be aware of the patient's beliefs in case their expectations of the consultation don't meet what you're going to deliver. You're going to be behind from the start.
Yeah.
Anything else on beliefs or emotions?
No, that's fine for now, I think.
Yeah. Lifestyle. So, again, with all pain disorders, these things can be important. The sleep is the one that came to mind for me. So interestingly, even in pregnant women, some of the work we've done, we've found that sleep is more disturbed in those with more severe pelvic girdle pain than those without. Sleep's important in terms of sensitization of the entire system. Yeah. So sleep can be an issue. Work is often during pregnancy, again, like heavier work has been associated with development of pelvic girdle pain. There are a couple of things to come to mind. Are there any things from your patients that you pick up?
Yeah, the other one's activity levels, particularly around exercise. So probably in most, but particularly in pregnant women, because it's probably more recognised and people have access to information when they're pregnant around this. They can Google it quite easily. So a lot of people will have pain with exercise, so that may need to be modified depending on how sensitive their joint is, but a lot of other people are avoidant of exercise when they're pregnant because of this concern. And it's generally, for some people, a period of elevated concern anyway.
Yeah.
And if you're a naturally anxious person and exercise is usually your outlet, then you can get really stuck in a cycle there. So understanding if exercise is bothering them and what they're currently doing and how important exercise is to them normally, that would definitely shape part of what I'm going to look at, but also part of my advice for that person as well.
Yeah. Good. Co-morbidity, so I like to kind of break this into two groups. One is around other functions within the pelvis, so particularly around continence and sexual dysfunction.
Yeah.
Again, some of the research would suggest that potentially as many as 50% of people with pelvic girdle pain will also have some issue with continence or sexual dysfunction. That also doesn't just affect females, males can be included in that.
Yeah.
One of the things that I learned from talking to the Women's Health Group was just asking, have you had any changes in your bowel or bladder, might not be enough to really understand what a continence issue, and you might have to dig a bit deeper on that.
Yeah. Should we? Do you need to dig a bit deeper than that?
Well, it depends, obviously. But yeah, I think given there's 50% crossover of these conditions, people might not understand that a problem is a problem.
Yeah.
So to know about that probably is important. The management might not actually change that much, and maybe
Sure.
we'll talk about that in management. But
I guess an easy way would be to say we know people that have pain in this area commonly have impacts on those different areas of function in terms of bowel or bladder or sexual function. So you could let us know if that's an issue for you. And even if they flag it as yes, if that's beyond your expertise, you don't need to go any further. But it might be, is that something you would also like some assistance with? And obviously, as we advocate on referral to someone with more expertise, either within physio or other health practitioners might be appropriate there. But even just acknowledging it can be a really good starting point for some patients.
Yeah, absolutely. So that's a really nice way of just tweaking that questioning a little bit to make it much less threatening and easier to get into.
And you were going to, a second part of the comorbidities?
Yeah, the second part was around pain comorbidities. So we talked about in a previous episode the label of pelvic pain. So particularly other pain issues in the pelvis that aren't so much musculoskeletal in nature. Other disorders that are linked by sensitivity, so potentially unexplained stomach complaints, irritable bowel syndrome, migraines, menstrual pain. Restless legs isn't a painful syndrome, but can be associated with musculoskeletal pains as well. So just if there's a sense that these things are going on, you might be thinking about a broader sensitivity issue than just an isolated pelvic issue. And we haven't spoken about that much, but it's easy to focus on the pelvis when you've got a whole person here.
And then the other comorbidities we kind of addressed a little bit in the screening, but around other general health conditions or inflammatory arthritis conditions, histories of cancer, those sorts of things that we just want to be aware of to see if that fits with their story or not, particularly in the presence of insidious onset or more non-mechanical symptom presentation.
Other risks, I just put this in there because there is information that if your mother's had pelvic girdle pain or your sister's had it, you're more likely to. Potentially over multiple pregnancies, it could increase your risk a little bit. They're not things that we can modify that much. So, but maybe just to know that, because again, maybe there's a genetic component to that, but maybe there's a beliefs component to that as well. And outcomes. So this is around having good outcome measures in place. We could use, often people can use the low back ones, but there's the pelvic girdle pain questionnaire, which could be recommended, for these people particularly. It's not pregnancy specific from memory, so it's just tasks that are more common to people that might have that. But I think a low back pain one would work just as well.
Or even a lower extremity one. But either way, you want to measure that day one, because particularly some of these disorders can last for a period of time, or they may already be quite persistent already. So we've got to have something to check back in on, not just our measurements of a few maybe or maybe not relevant assessment components to help us judge is the management we're delivering effective or helping this person recover.
Absolutely.
Good.
Okay, so any other thoughts on the subjective assessment and what you might be thinking? I think we covered
that's fine.
Most of it. So as part of our goal of increasing clinical reasoning, so once you've gathered this information, what do you do with it, Tim?
Well, we've put story there as the first point for a good reason. I think with any patient that we see, but particularly obviously around this pelvic girdle pain at the moment, the story needs to make sense. So if you haven't got sense out of that story at the starting point, heading into your physical exam's going to be very difficult. And the sense might be that it doesn't make clear mechanical, sense or a clear mechanical pattern to their symptoms. That's okay, because maybe it was insidious onset, and then you'd start be thinking around, well, are other things driving this?
Yeah, good.
Anything else on story?
No, but I think, yes, actually, I guess it's just that opportunity for the person to feel listened to.
So you can do a quick reflection back at the end of your subjective saying, this is what I've heard, this is how it started, these are your main issues, this is what's driving it, does that fit? And, 2 out of 10 times you've missed something, and that gives the person an opportunity to give you another very useful piece of information.
Yeah. Yep. Or they can dribble on longer than you want them to, so you've got to be careful of that as well. Concern, so...
Yeah, just you'd want some sense of how concerned am I about this person in front of me. Concern would come much more around history of significant trauma, much more insidious onset where there's a very non-mechanical pattern. So do we need to screen out, do more red flag focus assessment, if you like, to check out for red flag disorders? But in most instances, if you listen to the story, it should make sense to quite a strong degree. So you'd go, right, I'm not concerned on this. I need to look at what I need to focus on now during my examination to clarify that. Yeah. And
do you think also in an ongoing manner around concern, if they're not responding in the way you expect them to over a period of time, that might be important as well? Yeah,
and that concern may be for medical reasons, or it might be, hang on, just what I'm looking at or the angle I'm approaching this from isn't being effective in this instance.
Yeah, so it fits with having those outcome measures as well. Screen?
Yeah, screen can be, particularly for your physical exam, what do I need to screen? And obviously, for most of these patients, like you've mentioned, is the hip joint potentially a source of symptoms? Is the lumbar spine? Is there neural tissue? So we can use those kind of bits of information to judge what's the focus of my physical examination. But it might also be, hang on, is there signs of this is a more widespread disorder? So there's not actually an individual structure. So do I need to screen the whole system for broader pain sensitivity, for example?
Yeah.
That would be one key one. Anything else from your end?
Well, I was wondering, do you regularly screen the sacroiliac joints out?
Yeah, absolutely. So I do that for pretty much all my patients with lumbar spine pain, because I'm now good at the test because I do them a lot, and we know they're useful. They don't take very long.
Yep.
So it can be an important part of saying to a patient what you don't have, equally as important saying what it most likely is.
Good. I better lift my game on that one.
Yeah.
Focus.
Yeah, it's really bringing those 3 points together and say, right, what's the focus of this examination? Because not everyone with pelvic girdle pain gets exactly the same, I guess, amount of physical examination or the order of the physical examination, because your story should be directing that. If it's very mechanical, get in, screen out to identify where the likely source of symptoms are, and then the other factors driving that. But if it's non-mechanical, it might be different. Do you use a similar approach?
Yeah, absolutely. Yeah. All right, good. Anything else on the reasoning?
No, well, we've sort of said it there, but you should have some diagnostic hypotheses going in to your physical exam in terms of more targeted, localised structure versus maybe a broader issue, or more maybe a concern for a red flag disorder. So you need to be clear on that to help target what you're really going to test in your first session.
Yeah, and prioritise accordingly.
Yeah.
Great. Any questions, Tim?
Not from me, but other people may have some, or bits of comments or observations they might want to add to that, so they can contact us on that email address on the screen that you'll be checking very regularly.
Yes, I will not be doing that. education@painoptions.com.au, but please send through any information and we'll happily reply. This is just a reminder that this is an ongoing series, and what are we doing next time, Tim? We're going to perform the pain provocation test, so we'll be off the chairs and out with the treatment couch, so that'll be good.
Look forward to seeing you in action, Darren.
Oh, good. Bye.
See ya.